So carrying on with our thinking about the physiology of the capillary, we've moved on to thinking about abnormal conditions. So here we have our capillary that we're familiar with, and we know that the cells are in this extracellular or extravascular space. In between the cells is the interstitial fluid. Inside the vessel, of course, is the intravascular fluid. Now, there's two ways for you to spell edema there. Pick which one you would like. But I want to think about the causes of edema. And the first cause is increased hydrostatic pressure. So increased hydrostatic pressure. If you've watched the previous videos in this series, you'll know that the tissue fluid is formed at the arterial end of the capillary, where the hydrostatic pressure is greater than the osmotic pressure. That the tissue fluid is reabsorbed at the venous end of the capillary, where the osmotic pressure is now greater than the reduced hydrostatic pressure associated with the venous end of the capillary. But there's increased hydrostatic pressure, then that's going to increase the pressure in the capillary, within the capillary. So if there's increased pressure within the capillary, that's going to counter the osmotic suction effect, which you might remember is generated by the large plasma protein molecules, the oncotic pressure. So we have the oncotic, that is the osmotic pressure sucking in, and we have the hydrostatic pressure pushing out. So if we've got increased hydrostatic pressure, more pressure pushing out, even if the oncotic pressure, the osmotic pressure sucking in is normal, there's going to be more pushing out than there would normally be. So if there's more pressure in here, another simple way to look at it, if there's more pressure in here, you can probably see that's going to make it harder for the tissue fluid to be reabsorbed. So this tissue fluid is going to find it harder to get in because there's already an increased pressure in here. The increased hydrostatic pressure in the vessel is going to resist the reabsorption of tissue fluid from outside the vessel. So this could be localized or it could be systemic. For example, if it's systemic, that could be caused by heart failure. So if there's a right heart failure, that might initially lead to systemic edema. If there's a left heart failure, a left ventricular failure, that could initially lead to pulmonary edema. So there could be systemic causes, but there could also be localized causes. So it could be localized. So we've got systemic as one possible cause, local, or relatively local as another. For example, we could have an acute venous obstruction. As might occur in deep venous thrombosis, where we could have an acute development of edema because of the obstruction. Because normally the fluid in the blood is leaving this way, it's going out that way. But if there's a relative obstruction here, if there's a traffic jam, as it were, downstream, there's going to be this backlog of fluid. Because this capillary, of course, is draining into venules, the venules are draining into veins, and if one of the deep veins is obstructed, the flow of fluid from the capillary out into the venous system is going to be inhibited. Or there could be a chronic venous obstruction. As we get in chronic venous insufficiency. very often caused by failure of the valvular system in the larger veins. But again, if the blood's damming back into the larger veins, it's going to dam back into the capillaries and it's going to increase hydrostatic pressure. So that's my first cause of edema, increased hydrostatic pressure. Now the next one I want to talk about is decreased colloidal osmotic pressure. Now we know there's a lot of sodium in here and a lot of sodium out there, but that kind of balances out. So the difference between the osmotic molecules in the intravascular compartment and in the interstitial compartment is that in the intravascular compartment we have more plasma proteins. Albumin is the main one. There's also the globulins, the immune proteins, the fibrinogen. But these are generating this osmotic suction effect. The oncotic pressure is that generated particularly by the large molecules. So if that is decreased, if there's a decreased suction effect, so instead of getting a big suction effect in, as we would get with normal levels of plasma protein, we're going to get a reduced suctioning effect. So normally at the venous end of the capillary, the oncotic pressure is going to exceed the hydrostatic pressure and there's going to be net reabsorption of tissue fluid. But if we don't have the osmotic pressure inside sucking in, there's less sucking in pressure, more fluid again will be retained in the tissue spaces. So the increased hydrostatic pressure inside will cause the accumulation of tissue fluid, that is edema. And the reduced internal osmotic oncotic pressure sucking the fluid back in will also lead to this as well. So this could be caused by malnutrition. Just not getting enough protein in the diet, because the albumin in here, this large albumin molecule is of course made up of amino acids. It's made from amino acids. So we need to eat the protein. The proteins need to be digested in the gastrointestinal tract, broken down into their constituent amino acids. The constituent amino acids will travel to the liver in the blood, and the liver will synthesize those amino acids into albumin. But if there's no amino acids or not enough amino acids, the liver can no longer perform that function. So simple malnutrition can lead to reduced colloidal osmotic pressure. And we've mentioned that the liver produces most of the plasma proteins, so liver failure, for whatever cause, if the liver is incapable of producing them. So there might be cirrhosis of the liver, or a hepatitis, or alcoholic hepatitis, for example, where the liver is not working properly. It tends to be in longer term liver conditions like cirrhosis where we get the edema. So failure to make the proteins, or the proteins might be getting lost. So nephrotic syndrome is where the kidneys are leaking protein. There'll be a proteinuria because the proteins are leaking out of the kidneys, normally due to problems with the glomeruli. So we can have the increased hydrostatic pressure keeping the fluid out, stopping it being reabsorbed, or we can have the decreased colloidal osmotic pressure, reducing the suction effect back in. But one of the interesting things is that in both of these conditions, the wall of the blood vessel is intact. It's still tight. There is a normal blood vessel wall. So the edematous fluids caused by the increased hydrostatic pressure and the reduced colloidal osmotic pressure. We call those transudates. It's a transudate. The nature of the increased interstitial fluid is normal. It's like interstitial fluid is normally. We'll notice some differences in a minute between transudates and the other sort is the exudates. So let's think about causes of exudates now. So increased hydrostatic pressure and decreased colloidal osmotic pressure will lead to formation of transudates. It's an edema. There's too much tissue fluid, but it's a transudate. Now the other one is the exudates. Now exudates is the type of edema caused by increased vascular permeability. So there's increased vascular permeability. Increased vascular permeability. Now, in increased vascular permeability, the walls of the blood vessels become more permeable. Typically, this is caused by, if we think about a normal capillary here with fairly tight junctions. We've said in previous videos that, I know I've drawn these gaps fairly large here, but these only actually represent 1/1000th of the internal surface area of the capillary. So instead of having tight junctions like this, if there's increased vascular permeability, these are going to widen out. There's going to be bigger gaps between the individual endothelial cells. And I think you can see through these bigger gaps now, there's plenty of spaces for bigger material to get out. So classically, of course, this might be caused by inflammation. So inflammation is going to cause localized vasodilation, increasing the vascular permeability of the capillary. So we could say that the capillary is no longer tight. The walls are looser. So if you think about the individual cells, if the capillary is going to dilate, it's going to increase the size of the gaps. There's going to be inflammation. So there could be peritonitis, tuberculosis. And this also occurs in malignancy. So for example, you might get a pleural effusion. Let me write that word again. A pleural effusion, where you get exudate going into the pleural space, causing collapse of the lung. It's a common problem in lung malignancy. It affects about 40% of cases. It's a sign of very advanced incurable disease, unfortunately, and we often have to treat it palliatively. But because there's going to be dilation of the capillaries due to the inflammatory malignant processes, pleural effusion can develop. And we can also get increased permeability in chronic venous hypertension. So in acute venous hypertension, you're going to get the increased hydrostatic pressure. But over time, if the hydrostatic pressure is increased over a long period of time, that's going to physically push apart the walls of the capillary, causing dilation, and that will cause increased vascular permeability. You can even get red cells leaking out sometimes, and that leads to the brown staining, the hemosiderin that you can sometimes see in chronic venous hypertension. So initially in the acute situations, it tends to be a transudate in venous obstruction, but as it becomes more long-term, it can become more of an exudate. I think I'll just deal with the last one now. The last cause of edema is lymphatic obstruction. Lymphatic obstruction. Now, the lymphatic vessels are located, the lymphatic capillaries are located in the tissue spaces, and they're going to drain away excess tissue fluids. So we have these lymphatic, blind-ended lymphatic capillaries, and they'll join up into forming larger lymphatic vessels, draining the lymphatic fluid away. Now, if these are blocked downstream, then again the fluid can't get away. So you're going to get more fluid left in the tissue spaces. But as well as that, it's particularly important that we have good lymphatic drainage, because some proteins do actually escape from the intravascular compartment into the interstitial compartment. And these proteins need to be drained away in the lymphatics. If they're not, because there's a lymphatic obstruction, then I think you can see that's going to increase the osmotic potential of the interstitial fluid, attracting much more water. So that's it's quite a problem really, and you can get very severe edema. So the lymphatics could be damaged by trauma, surgery. Surgery can damage the lymphatic ducts, or surgeons can sometimes remove the lymph nodes. Often it occurs after infection. So after an episode of cellulitis, there can be damage to the lymphatic vessels. Because in cellulitis, if there's infection in the tissue, the bacteria are going to drain into the lymphatics and can damage the inside of the lymphatics. Tumours can press on lymphatic vessels, so there's a big tumour there that can press on the lymphatic vessels. Malignant obstruction. Sometimes it's congenital. Just people are born with it. We do see quite bad malignant obstructions. Can cause gross edema sometimes, complicating the palliative care situation. So these are exudates. Now, I realise it might be a bit confusing, so what I want to do is just clarify the difference between the transudates caused by the hydrostatic pressure and the increased hydrostatic pressure and the reduced colloidal osmotic pressure, as opposed to the exudates. I mean, they're both edemas. They both cause increased amounts of tissue fluid to be retained in the interstitial spaces. But we notice that there's a difference between them. So, transudates. And exudates. And as we've said, in transudates, the vessel is intact. The junctions are tight. In exudates, very often there's increased permeability in the vessel, or there's obstruction to the lymphatics. Now, in a transudate, another way to remember it is transudates are often fairly transparent. Now, transudates have a low specific gravity. Specific gravity is the ratio between water and the substance we're considering. So low specific gravity means it's quite a watery solution, a relatively light solution. Exudates have a higher specific gravity. In other words, they're heavier. And that's often because transudates have low protein, whereas exudates have higher amounts of protein. And we can explain this. So low protein in transudates, because they're caused by the increased hydrostatic pressure or the reduced oncotic pressure, we're not getting the leakage of the proteins of the heavier components. Whereas with the exudates, where we've got increased vascular permeability, then the proteins are able to leak out of the vessel. So they accumulate in the edematous fluid, but it's kind of an exudate edematous fluid. And likewise with cells, transudates have low white cells, but exudates can have higher amounts of cells, especially if it's an inflammatory or an infectious condition. So the transudates, because they don't contain the protein in the cells, the fluids are often quite clear. Whereas with exudates, they're often cloudy. And if we look for other things, biochemists will look for other components like transudates are low in cholesterol. Whereas again, the cholesterol can leak out the blood in an exudate and it's higher in cholesterol. And particularly if we're thinking about the pleural exudates, pleural effusion, the exudate's going to contain lactic dehydrogenase, for example, which is an enzyme produced by the pleural membranes when it's inflamed or when it's subject to a malignant process, whereas the transudate is going to be low in lactic dehydrogenase. So we can see these differences between the transudates with the tight junctions with the vessels intact. Low specific gravity because the proteins are kept in, the white cells are kept in. That means it's fairly clear, and other chemical components of the blood are kept in. Whereas with the exudates, because we have the increased vascular permeability usually, increased specific gravity because there's more protein, there's more white cells, that can make it cloudy, and other components of the blood can escape. Plus this is sort of a localized inflammatory marker, the LDH. With the lymphatic obstruction, again, you're going to get the increased amounts of protein because the proteins aren't drained away in the lymphatic fluid. So these are both causes of edema. They're both edemas, but they have these different characteristics. And this is very important when we learn more about diseases. So transudates are often heart failures, for example, or cirrhosis of the liver can lead to transudates. Whereas with the exudates, we're thinking about inflammatory conditions, infection, tuberculosis, peritonitis, infectious conditions, and of course malignancy as well. So edema, exudates, transudates. But basically, getting back to the very simple idea, there's only 4 causes of edema: increased hydrostatic pressure, decreased colloidal osmotic pressure, increased vascular permeability, or lymphatic obstruction. So whenever you see edema, try and work out which of these 4 it is, and then work out whether we're thinking about an exudate or a transudate and the implications that has for our patients.